Recording. Said we're recording. One day I'll work out how to do this in actual PowerPoint, but I don't use PowerPoint, I use Google. So yesterday was Heart Happy Face, and we did cross over into a lot of this. Today's going to be Heart Sad Face. So just, pathologies and just the simple way to how to work your way through them. So we have touched on this, I guess, at the first week, just different kinds of shock. So hypotension sucks. I wrote these at like 6 in the morning while Scarlett was, trying to mess with me. So all of these were written like when I was on a home lockdown and having to do tutes in the morning from my house. So low perfusion pressure. We have our equation for perfusion pressure, but basically it's less than the mean arterial pressure. So if you have low blood pressure, do you have a low mean arterial pressure? Is that going to suck? Yeah. And if you're not delivering blood in terms of pressure to get through a solid organ, there is less oxygen delivery, there's less glucose delivery, there's less water delivery, there's less clearance of heat, and there's less clearance of CO2. Yeah? Do all of those things sound like you're going to cook? Yeah. Why? Because your mitochondria keep trying to burn stuff. And if you don't clear away metabolites and feed them when they're hungry, they just eat you. And that's, your infarction, necrosis, and all that kind of stuff. So, literal screen grabs from my Instagram. Like, that's it. A whole lot of this stuff is like, why would I bother trying to write all this when somebody does a pretty picture on Instagram and I can screen grab it and drop it straight into a thing in Google, in my Google Slides. So that's how I write, teach now. Anyway, what does hypovolemic mean? Low volume. And why would you have a low blood volume? Yeah, so not enough in or bleeding is one version of too much out, so hemorrhaging, or too much out in the sense of fluid loss because of vomiting and diarrhea, or sweating. Yeah, remember, this is Australia. You go to the middle of the outback for 3 hours and you will die. And then people decide they want to go running in that because I think people want to commit suicide. Like, those crazy ultra-marathon-y things that people run, and they go and do that in the Northern Territory because, there's not snakes and other shit out there. Legit story, we had somebody that died in our ICU because they couldn't work out what their problem was. They were in shock. It was hypovolemic. It was really hot. They also probably got bitten by a snake, but nobody knew what part of their sad face was happening, and you can't treat everything at once. So hypovolemic is a low volume for any of those reasons. And what will that do to your blood pressure? Yeah, just think of a balloon with less water in there. Yeah. Now, do you want to have a low blood pressure? No. So what does your heart rate do? Increase. So now we've got heart rate going up, but blood pressure low. Yeah. And your cardiac output will also be low because you just have less fluid in the system. Yeah. So as opposed to exercise where your heart rate goes up, your blood pressure goes up, and your cardiac output goes up. Yeah. These are not all going in the same direction. That's how I want you to think about the basis of how these numbers work, and then at the end point, shock is just not enough oxygen delivery and not enough everything else delivered. Yeah. So a low volume, and how would we fix a low volume problem? Yeah. So do you just drink water when you need to drink water? Yeah. And if somebody can't drink water because they've got vomiting and diarrhea, what do we do here? Yeah, give them an IV drip. Now, if you're in some kind of we'll say third world country situation like Haiti, where there's earthquakes and hurricanes and volcanoes all at the same time. I don't know about the volcanoes, but you reckon you've got some pretty messed up infrastructure after all of that, and you reckon the waterborne illness is going to spread rampantly? So who's going to die from vomiting and diarrhea? Well, that's everyone. So who? What age groups? Babies and old people. Yeah. Now, if you have modern infrastructure, do you just stick a cannula in all of them and rehydrate them? Yeah, but you don't have all that infrastructure there. So how do you get fluid into somebody quicker than just drinking water, but when you don't have an IV? Not really. Think about when you've been hungover. What have you had? Gatorade. No sugar. So why is Gatorade better than just water? No, that's not why it's better. No, it's the sugar makes it taste nice. And? That's the salt. What else is in Gatorade other than salt? And? Sugar. Yeah? Now, why is that better than just drinking water? Osmosis. Osmosis will happen faster. Water goes into your stomach, yeah? Say it travels at a rate of 10 to get from your stomach into your blood, yeah? How do you make it faster than that? Put some sugar in there. Sugar will make it travel faster. We'll call it 12, osmosis. The glucose gets transported and the water goes with the glucose, yeah? So it increases the rate at which it moves, yeah? Now, what else gets transported? Salt. So the salt gets transported, so say 10 whatever per hour, it increases to 12 if you add sugar. It increases to 13 if you add salt, yeah? But if you have co-transport of glucose and sodium, it doesn't add them, it like multiplies them. So now it goes from 10 to 20, not 10 to 15. Does that make sense? In terms of the rate at which you absorb it. And that's the purpose of those electrolyte sports drinks or whatever, is for diarrhea. What do people have them for? Sitting in the gym, putting pictures on Instagram rather than actually working out. I mean, not you, but that's on. So, unless you're doing like proper things for longer than an hour, you don't need electrolyte. You have a glass of milk before you go to the gym, and then a couple of pretzels after the fact. Yeah, or a beer. I was going to say in terms of what's the best post-workout, like pink milk or chocolate milk or something. Yeah. Pink milk. Pink milk. So replace the volume with water if they can drink, and or if they have diarrhea or whatever. It works really quickly. And if you just have not a pump but a gravity-fed bag, putting electrolytes and sugar into water makes you absorb it at nearly the same rate as a gravity-fed drip, which is pretty good. It sounds like it'll save people. Yeah. But what you have to get them to do is boil the water first and then stir in the stuff and then drink it. Sound like a good plan if you're in some place with lots of waterborne illness? Yes. You've all travelled, had to drink bottled water or boiled water. So, cardiogenic shock. Well, what's cardio mean? So it's heart Sadface. What is that going to do to your cardiac output? Decrease. And what's that going to do to your blood pressure? Yeah. Now, if you have less blood pressure, what's going to happen to the perfusion of your coronary arteries? Decrease. So what's going to happen to the strength of your ventricle? And what's going to happen to the pressure it generates? Less. So what's going to happen to the pressure in your coronary arteries? Yeah. That's the downward spiral where the problem is the cardiac muscle. So why do people have cardiac muscle weakness? Atherosclerosis causing of the arteries, and then why is that a problem for the ventricle? Yeah. Yeah. So can the ventricle work as hard as it needs to? No. And in the short term, it kind of works around it, and in the long term, do you reckon the ventricle gets weak or dilates or any of those things? Yeah.
Why wouldn't it?
Because it can't work harder because it's not getting enough oxygen and glucose, and I think your heart actually runs on, I want to say, fatty acids, and all ketones and all lactate. I think your heart can run on lactate. There's a vague memory that it runs on all sorts of stuff that's not just glucose. That's all. Because lactate has multiple carbons, so you can still release energy from it. Depends on which definition of death you're using. So your heart, if you just took somebody's head clean off, but then piped one side to the other, would the heart keep beating as long as you were pushing blood from your carotid back into your jugular?
Yeah.
Probably. Yeah. Why? Because does your heart need anything to tell it to contract? No. What is the internal pacemaker of your heart? Sinoatrial node. Yeah. And if that isn't working, what is the next node in the chain? AV node, and that has its own clock rate of 30 to 40. You know when they talk about vasovagal, that means your SA node has gone to 0, but your junctional escape rhythm, 30 to 40, or your ventricular escape rhythm, 20 to 30. They have their own internal pace as well. Yeah. Vagal means what? What nerve? Vagus. And what does your vagus nerve do? Increase or decrease your heart rate? Decrease. So is it sympathetic or parasympathetic? So anyone that says vasovagal, if they weren't bradycardic, you are making shit up. Yeah, you have to be bradycardic to use the word vagal in a sentence. It's vaso, sure, artery, sad face. The person fell over, cool, hypotension. Yeah, it's not a vasovagal if they weren't bradycardic. It is syncope. It's called vasovagal syncope. Syncope is too hard a word for a lot of people, so they say vasovagal because of alliteration. They mean syncope. They don't mean bradycardia. It annoys the hell out of me as somebody that, learned English. I learned English well. Yeah, because and somebody stubbed a goddamn toe and fell down. Oh, they had a no, you dropped them. Yeah, no, you dropped them. That's all that happened. Yeah. Anyway, annoys the hell out of me. Vagus means vagus nerve, means parasympathetic, means bradycardia. Those are the definitions. If you know those definitions, so much of the rest of your life is easier. Syncope is falling down. Who cares? Why? Like, did they land hard or did they land soft? If the answer is they landed soft, no paperwork. If they landed hard, you're in trouble. Yeah, remember our job? Have something soft to land on that's not you. That's your purpose in the acute setting. Yeah. Why we spend 15 minutes setting up and 1 minute moving a patient. Yeah, like yesterday. What did he do? Yeah. What did he do? Tank. Yeah, you got to yell louder.
Yeah. So I was giving her an aftercare. She was like sliding down slowly, and so her neck put on the footrest, and her butt was sliding between the chair and the footrest. And then I shoved my knee under her, and I was like, yeah. And no one came for like 5 minutes, and then the mum came, and she's like, oh, okay. And it's fine.
Yeah.
My knee was melting.
I have to have words with them. So, the cardiac shock. Part B of what is a problem in cardiogenic shock is think about your ventricle, yeah? When your ventricle contracts, if you're looking at the heart, what happens to all the arteries running through the ventricle? Do they get squashed? So can your coronary arteries perfuse during systole? No. So they can only perfuse during diastole. So whereas your mean arterial pressure is important for brain perfusion, it's your diastolic pressure that's important for coronary artery perfusion, yeah? Which is a much lower pressure. Make sense? So yeah, you compound, I guess, some of those problems. Low urine output. Remember we talked about urine output? If your kidneys are fine, your urine output largely matches your heart happy or heart bad. So if somebody has okay kidneys, but they have a low urine output, are they lacking in volume or are they lacking in blood flow because their heart is the problem? Yeah. And the solution is generally just put volume into them and see what happens. If volume was the problem, do your numbers get better? Yeah. And if your heart was the problem, do your numbers get better? And how would they look at your heart to see whether your heart was moving well or not? Ultrasound. So electrically, it's very quick. Echo, you've got to get the machine and have a look. All of those. And how do you look at the damage? How would you look for damage? Troponins. Now, if you come in with chest pain, are your troponins going to be elevated if you just get straight to hospital? No, it takes time for the muscle to break down. So it'll be 0 at time 0 sometimes, but at 8 hours it'll be much higher. And then hopefully fix the problem, and then the 24-hour measure will be lower. Yeah. But yeah, if you have the chest pain and get straight to hospital, there's not time for the muscle to break down and leak into your blood. So you might not actually have a significant troponin leak. Neurogenic is just think autonomic nervous system. Yeah. Do we have patients with messed up autonomic nervous systems? Yeah. The best way to do that is just to lie flat for 2 weeks. Is that going to mess with your ability to posturally acclimatize? Yeah. Now, do our patients also have strokes and or other problems in their heads? Is that going to mess with your auto-regulation? Do we do anything differently with them? No. We do the same thing with everyone. Sit on the edge of the bed and wait 2 minutes. Yeah. Have you ever seen me do anything other than that? No. Do we have less problems if we do that? Because if there's a problem, you're already on something soft you can lie down from. Anaphylaxis. That's where we need your mate Daniel and his peanut allergy. What's going to happen to Daniel if I throw peanuts at him? He'll die. Why will he die? Exactly. It's weak. Definitely won't survive a Snickers. What will happen? Why would his airways close up? Correct. Inflammation and vasodilation in these blood vessels. Angioedema. Yeah. Angio, blood vessel, edema, edema. Yeah. So you're getting vasodilation in here. Yeah. What's going to happen to his breathing? Gas movement, because there is that force choke. Exactly. Getting Darth Vader. Very terrifying. What happens in your blood pressure is all sorts of weird stuff happens to some blood vessels dilate, constrict, other weird things. Now, what is the solution to anaphylaxis? EpiPen. What is the epi in EpiPen? Epinephrine. And why is it called epinephrine? Because what do we otherwise call it in this country? Adrenaline. Epi, above, nephrine, the kidney. Adrenaline, add to the renals. What's the thing you add to the renals? The adrenal gland. What is the thing above the renals? The epinephrine. Epinephrine. Yeah? So, part B of all that is, why do we call it that? Because you know how like we call it hoovering instead of vacuuming? Yeah, it's just a brand name, the US. Yeah? So take epinephrine, take the E off the end, and then somebody just trademarked that, and then that's the drug brand as opposed to the drug name type thing. Same with adrenaline. It's like, oh, let's just take the E off the end and then trademark that just to confuse people. So anaphylaxis is a reaction to peanuts or a reaction to anything. What's some other common things that you've heard of people being allergic to? Bees, shellfish, yeah. Any of those kind of foodie type things. And the other is when people have medications. The common one we see here is you have an anaphylactic reaction to anesthetic agents. Very common cause of people ending up in the ICU because they just have some weird reaction to the drugs. You try to die. Fortunately, you have an anaesthetist standing right there. Does he know how to handle airways? Yeah, that's his job. Yeah. So how do you know? You come close to dying then and there, and the man that gets paid a lot of money to make you not die makes you not die. Yeah. So that's the bee stings and a lot of food allergies. Yeah. The first one you had a mild reaction, and your immune system or whatever, your inflammatory system gets primed, and it's the second time you have the full blown. Yeah. So yeah, the airway edema is because of vasodilation. So how do we fix the edema? Well, you need vasoconstriction, and that's how adrenaline helps. Yeah, adrenaline has alpha and beta effects. Think about the beta effects as you run further and faster and whatever. So the beta effects are going to do what to your airways? Open them, bronchodilation. They're going to do what to, say, your skeletal muscle? You want more blood flow or less? More, so it's going to be dilation there. Yeah. Now, what about your gastrointestinal tract? You want less blood there. That's the alpha effects. Yeah. So the beta effects on your heart will be increasing or decreasing rate? Increasing rate. Yeah. So beta adrenergic effects on your heart are tachycardia. Now, if you have that increase in heart rate, what's that going to do to your blood pressure? Increase it. Yeah. Now, if you have hypertension, is that a bad thing for you? So if you have tachycardia and hypertension, how could I decrease your heart rate? With a beta blocker, metoprolol, propranolol, all those olols, yeah? They are beta blockers. What are they going to do to your SA node? Make it go faster or slower? Slower. So if you bring somebody's heart rate down, you bring down their cardiac output and you bring down their blood pressure. Does that make sense? Yeah. So that's you've got to remember these are alpha and beta effects and they're all a bit weird, but just think about, oh yeah, that happens with an EpiPen. So you're going to have dilation and the solution is constriction. Rather than no alpha and beta effects, just think, well, why do they give this person? What about what is that drug called? Salbutamol, and it is a beta 2 adrenergic receptor agonist. Yeah? So remember, adrenaline, panic, bronchodilation, more airflow. So if you just stuck adrenaline in a nebulizer mask, yeah, would that also have the same effect in their lungs? Yeah. And also, would that have the same effect for vasoconstriction in these blood vessels? So the other force choke, not anaphylaxis, that we see is actual airway vocal cord edema for any number of reasons. just really bad wisdom tooth infection and all sorts of stuff like that sometimes. But also when somebody's been intubated, their vocal cords have been traumatized and swollen. You've got a tube in there, and you take the tube out. And what does the swelling do? Do that. Anyone know what that's called? It starts with an S. Suffocation, definitely. It's called stridor. Yeah? And it literally sounds like you're getting force choked. So the solution to that is literally stick adrenaline in a neb mask and have them inhale it to vasoconstrict locally and get them to breathe better. It's a beta 2, so beta effects are panicky, beta 2 adrenergic receptor agonist. Agonist increasing, blocker decreasing. So a beta agonist will increase your heart rate, a beta blocker will decrease your heart rate. Make sense? Any of you ever have or had Ventolin? You feel a bit twitchy? Yeah, a little panicky. That's all. But it's all. Remember, all these things are also neurotransmitters. Yeah, like adrenaline, noradrenaline are neurotransmitters as well. So the last one in here, and it's actually the one we probably see the most commonly in the ICU, is septic shock. So what does sepsis mean? Systemic infection. So not a local problem, because a local problem would just be redness and swelling locally, but a systemic problem, which is redness and swelling everywhere. So if you have swelling, what happens to your arteries? Bigger or smaller? Vasodilation. So what's that going to do to your blood pressure? Low. But what's that going to do to your cardiac output? Actually high, because it's a wide open door we can all run out. But we're not running into each other, so we have less pressure. And remember, flow is one part of perfusion, and perfusion pressure is the other part. So if your MAP gets low, because you're vasodilated, what's going to happen to the pressure going through your kidneys? Less. And your kidney's going to be unhappy? Yeah, less than about 50. Is your brain going to be unhappy? Yeah. Are you going to be standing up or lying down? Lying down, so you don't have to push blood uphill anymore. Yeah. So if sepsis is an infection, do we have to treat the infection? Yeah. So antibiotics for bacteria, antivirals for a virus, and antifungals for tinea. You can have tinea in your brain. This is a real thing. That's all. So therein lies the problem. I don't know why that says decreased cardiac output. That will not happen. In a very vague way, if you vasodilate peripherally, yeah, more of your blood is peripherally, so there's less venous return in that sense. But yeah, I would say, yeah. I know from looking at echoes, when somebody is septic, yeah, because all their blood vessels are so vasodilated, their ejection fraction, instead of being 70%, is more like 90. Like the ventricle walls just touch each other because there's no resistance to flow. So the strength of the ventricle is used to pushing hard against something, and it's not having to push hard against something. Make sense? As opposed to in cardiogenic, where your ejection fraction is low because the muscle itself is weak. Hypertension also sucks. Yeah. Now, everyone has their own preset number, and that comes back to family history and genetics. Can you outrun your genetics? No. Can you make yourself die sooner? Yeah. That's all. So, why is hypertension good for you? Well, think about not fainting. So, in the sense of, yes, you won't fall down and break something. Fight or flight, so you're already a bit tweaked. So think about if you had to go hunt animals. Is that going to make you better at hunting animals? Yeah, and in the modern day, we're not hunting animals, we're hunting dollar bills, y'all. Yeah? That's it. So does it make you better at hunting whatever it is that you need to hunt? Yeah. Why? Because adrenaline speeds up the clock rate of your brain. Yeah? You know, like bullet time in the Matrix? It does that to you. Yeah. Some people cope with it better than others. But the short-term gain is, well, obviously you're going to live past 16. So does that make you old enough to pass your genetics on? Yeah. And are you more likely to go and, I don't know, kill a woolly mammoth when you're 16? If you're a bit more, yeah. But you might not live past 30. Did that matter back in the day? No. Yeah. Well, it's not that no one did. It's just like if you either died before you were 5 or you lived to, I don't know, we'll say 40 or 50. There was not necessarily a lot of in between that was, I mean, other than, people that got damaged and or killed by trying to get said mammoth. Yeah. I don't know if you've ever walked near an elephant, but imagine that, but like angry. Yeah. No, that's Mr. Snuffleupagus. Imagine Mr. Snuffleupagus, but like angry like an angry cat. So complications of hypertension are as such. So is it bad for your arteries? Why? Because they're more stressed on the inside. And is stress going to cause inflammation? And the inflammation will cause scarring. And what do we call that scarring? Atherosclerosis. So if you have stressed the collagen, and the vessel walls, what do we lay down like in our Achilles tendon and our plantar fascia that's stronger than collagen? Calcium. And does that sound like calcification of your arteries? Yeah. And then in that calcified artery, you get that's the plaque. You get other stuff built up like cholesterol or whatever else. But cholesterol is also part of the cell wall. So to say there is more cholesterol in that cell wall is to say there is more cell wall in the cell wall. It's not cholesterol bad. It's just you will die sooner because of your genetics. Yeah, that's where it kind of likes to, I guess, help. It's trying to help. No, so healthy tissue isn't inflamed and isn't scarred. And that's the thing. But the cholesterol is part of the cell wall, like your phospholipid. Yeah, that's part of all of that. Yeah, the cell wall is phospholipid. I don't pretend to know the ins and outs, but you can Google this. Actually, when I do these videos, Armando that works here does all those amazing drawings and all that kind of stuff. I'm just going to attach. You want the real science? Look at Armando's video. That's what I'll do. Put him in the descriptions. So these are all going on YouTube. He works here. I'll introduce you. But if ever you've watched, the amazing drawings, like where they talk about, like he was a med student at New South, I realized, and then he worked at St. George and then he's working here now. But yeah, I thought he was like, he's got this weird Europeanish kind of accent. I just did not know he was Australian. Very much. So bad for your arteries, and therefore you might need a stenting or coronary artery bypass. Is hypertension equally bad for your kidneys, like hypotension? Yeah. Yeah, that's one of the problems with hypertension. You end up with renal failure. And if your kidneys don't work, what happens to your electrolytes? Yeah, and then what do you need to solve that problem? Nope, not salt. This is the people that need to be on the low salt diet, the hypertension with kidney Sadface. Yeah, because you and I all eat plenty of salt, don't we? But we don't have a problem. But if you have a problem, then you need to be the ones not eating salt. Not everybody. It's like cholesterol. If you have that problem, sure, but not everybody. Because people with low cholesterol have equal incidence of heart disease, as well as high cholesterol. And in the middle, happy, inverted U shape, whatever it is. So you can apply the same thing to exercise, yeah? People who do zero exercise die sooner. People that do too much exercise also die sooner. Be in the middle bit, U shape or J shape curve. What's that? No, this is the problem. Like there's 100 people, there's 1,000 people on the waiting list and maybe 20 people get transplanted. Yeah. Take it easy. So you're on dialysis for a long time. So if the arteries are really stiff, does that make it easier or harder for blood to leave your ventricle? Harder. And if you're hypertensive, is your ventricle already having to work hard? So what happens to the ventricle? Yeah, so in the short term, does your muscle just remodel? Yeah, but think about I guess the body shape of somebody that does a lot of, like a sprinter that just is doing short distances, he's going to have a certain muscle type. A long distance runner will have a different shape and everything else. Yeah, both of those aren't necessarily good for you. And you have two ways of, if you're doing the same thing, your muscle will remodel. So if you have too much muscle because it's working harder, what happens to the inner wall, like the inner diameter of your ventricle? Less space, and that is diastolic failure. Yeah. The other version is you just have too much scarring and stretched out actin-myosin in your myocardium, and therefore the interconnections get more stretched out, and your ventricle gets bigger. Yeah. Dilatation, all those kind of words. Do the interconnections work as well? No. So you have a big internal chamber, but less ejection fraction and less strength of the muscle. Yeah. Those are two parts that your body just goes down one or the other, over the long term. Yeah, and that is either way, flow failure, stroke volume failure, and then congestive cardiac failure. So if your left ventricle fails, blood backs up into your left atrium and then backs up into your pulmonary veins. And how do we see that? On X-ray. Vascular opacity. Batman sign. Anyone's playing along. So pulmonary edema from left ventricular failure. Yeah. Now, if you have pulmonary edema, what's going to be happier, being more upright or being more flat?
Upright.
Upright. Why? There's just less blood in your chest. And if there's less blood in your chest, what happens to the weight of your lungs? Less heavy. So what happens to your work of breathing? Yeah. See? Simple physics. Cardiac arrest. Well, if you have calcification of your coronary arteries, can one of those plaques peel away and then block? Yeah. Acute myocardial infarction and all that kind of stuff. Yeah. But if you just have low flow because of a narrowing, downstream from there, is that going to be getting enough oxygen? So will that go a bit lactic? Yeah. And if it goes a bit lactic, what happens to the pH? Down. And what happens to the ability of all those gates and stuff and pumps to do their job? Yeah, so imagine something just opens up that shouldn't open up. Is that bit of your heart going to depolarize when it shouldn't? Yeah, so let's put that aside for a sec. Just think about your legs when you're running uphill. They get the burny, and you keep trying to run, and then what happens? Yeah, you stop, or you get a cramp, and a cramp is a contraction you didn't ask for. So let's apply the same thing to the heart. It's getting lactic and burny, and you experience that as the chest pains and whatever else. But then if it gets too acidic, then something depolarizes that shouldn't. Yeah? And then this bit of your heart starts doing this, and does that make the rest of your heart do this? What's that problem called? Fibrillation. And then you need the... Yeah? Same logic, let's apply it to your brain. What do we call brain fibrillating? Seizure. Yeah. And then when you run out of energy, like, think about your strokes, yeah? If this runs out of energy, is this doing anything? So what happens to that side of your body? Stops moving, yeah. Simplified version, but it's much the same. It's a problem of pH and electrolytes and gates and all that kind of stuff. But ATP, really. Run out of ATP, can you repolarize? No. Run out of ATP, can you repolarize? Run out of ATP, you can't repolarize. Rigor mortis, asystole, hemiplegia. Yeah? Cerebrovascular accident. So all the same problems for your coronary arteries are the problems for your carotid. Your arteries don't know where they are. Yeah, it's not like one of them selectively calcifies. Just all of them get calcified. So you'll have peripheral vascular disease, coronary artery disease, cerebrovascular disease. Yeah, and what are the number 1 and 2 ways to die? Cardiac, stroke. Yeah, and number 3 is cancer. So avoid all this by eating right and exercising right and getting enough sleep and staying off your phone and having good social interactions. What are you going to die of? Cancer. So that is the big C, separate to all these other C's. This is just, all the things we just mentioned. Avoid all of those and you'll have less fast cardiovascular disease. Yeah, you'll increase your risk of dying of cancer. Because if you live long enough, then that's, it gets you. This is all in, I'll send it around to you. No, this is all in the thing we already have. These are like, when we're asking people's histories, and we're basically just ticking boxes to say, yep, they have the diabetes. Yes, they have the high blood pressure. Yes, they have the smoking and or obesity. But really, like from insulin, diabetes, overweight, and or lack of physical activity, are they separate things or are they more like just one thing? Yeah, they're just like one thing. Now, as physios, does that not look like our job to like do the opposite of? Yeah. Encourage people to exercise and move more, move better, yeah? So if somebody's just doing dumb stuff and hurting themselves, are they going to move more or move less? Yeah, so it's your job to make them be less doing dumb stuff. But they're runners, so do they want to like do things well or just do them badly so they hurt themselves? Runners can't work in private practice. Imagine coming to me and saying, well, my foot really hurts, so I ran some more in the off chance that it might hurt less because it worked once before. You know when it worked? When you were 16. Remember back when you healed like Wolverine? Yeah. Do you heal like Wolverine now? No. And you're not my age. Yeah. You guys are half my age. Just wait till you get to 45. I have hair that's gone grey, but at least I have my hair. So, do I have a lack of physical activity? Of course I do. Do I have the Indian genetics that make me insulin resistant? Of course I do. Yeah, that's it. Like, I remember sitting there being 20 or thereabouts, and my mate literally looking at me going, so you basically, so number one is being male under 65, just increases your risk of all of these problems. Yeah, why? Because men are idiots. But also you're just more hypertensive and everything else. So what is the opposite of being my height and male? Being your height and not male. Who will live longer? Yeah. Yeah. Shorter people live longer. People with lower blood pressure live longer. Shorter people have less blood pressure. Yeah. Women tend to be smaller than men and so on and so forth. Yeah. And then also something about the Y chromosome and versus the X chromosome and other protective things. Yeah. Now, past the age of 65, all this stuff kind of levels off. Yeah. So I guess more women make it to 65, and then after that, you kind of decay. No. Anyway, the rate of anyway, whatever happens. Estrogen, sad face. Yeah. So, how can we help control blood pressure as physios? No, hypertension. I don't mean low. Exercise. How is exercise good for your blood pressure? Yeah, it does. It does good short-term effects, and does exercise decrease your body mass if you have excessive body mass? And does that decrease your blood pressure? Yeah, it's something like for every kilo, it's like 1 millimeter of mercury. So if you lose 10 kilos, you may bring your blood pressure down by 10 millimeters of mercury. Does that sound like a significant way to get from 140, which we have there, down to 130? And then you go from moderate to high risk to moderate to low risk. Yeah? Now, do you want them to do all that in like 1 month, 1 year, or 1 decade? 1 decade, yeah? Don't try and lose weight for 1 year. Try and lose weight for 2 decades, yeah? Like have a future plan of I want to be, if nothing else, the same weight. Because what does everyone do? Lose weight or gain weight across every year? Gain weight. So if your only goal is to not gain weight, you might accidentally lose weight. But if you're just trying to maintain, then you're not, doing anything that's too stressful, let's say. Yeah? And if you can at least find a nice level off, you might actually do better than that next year. But if all you're doing is like, lose weight, put on more weight, lose weight, put on more weight, yeah? Does that sound like the kind of things that Instagram promotes? Those teas that just make you crap your pants? Yeah, poop teas. As discussed before, is that good for you? No. What are you losing? Water mass. Like if you go back to like the 1900s, early 1900s, as opposed to the late 1900s, there was like in magazines, like you could buy a little capsule with tapeworm in there, and you gave yourself intestinal worms and lost weight. Yeah, those are your people that also. That's your turmeric lattes, people.
Can you take it out?
You need anti-worming. You need the ivermectin. You know your mates that are having ivermectin. Yeah, that's the. It's the imagine you are a red hat wearing anti-vaxxer. Yeah, that's ivermectin. It's the sign that you're a red hat wearing anti-vaxxer, as in pro-Trump. You know all those. Just. I don't watch TV, but if I did, that would be all you see on TV. No apologies to anyone I offended about the red hat thing. So, there. So these are the coronary arteries. I have never actually learned any of these properly other than left is left, right is right, posterior is posterior, and the circumflex is also posterior. It's not really important. Like, all we do is look at an operation report, and they'll say cabbage times 4, cabbage times 3, cabbage times 5. And that just means they patched around 5 arteries. Yeah. So where do the coronary arteries come off? Well, they're actually deep inside this bit here, which is called the aortic root, and it's actually inside the heart if you're looking at it like as a heart. So what they'll do is patch from above there down past the blockage. In the sense of how, other than coronary artery bypass grafting, how else can they improve blood flow in the arteries? Stenting. There you go. Pretty pictures. Does that explain it better and faster than I could explain it? So what have they done? An angiogram. They've gone in through your femoral artery or through your radial artery in the modern day, turned left, found your coronary arteries, inject a radio-opaque contrast, yeah, iodine type stuff. And you can see here that there is a narrowing. What would cause that narrowing? Atherosclerosis. So you get a balloon and the balloon inflates to push the atherosclerosis back, yeah? Will that increase the diameter of your artery? Yeah, but is that just going to come back again if you leave it? So what do you put in there to stop it closing up? Yeah, stent. Yeah. 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 All of those words. Now, you've got a foreign object inside your artery. Is that likely to cause blood to coagulate? Yeah, so the stents themselves have something in there that is anticoagulating, but then you might also be put on an anticoagulating agent. Yeah? So something better than just low-grade aspirin. All sorts of, so this is in your coronary arteries, so it won't cause a stroke, but a myocardial infarction. Yes. Yeah. Now, if it was in your carotid, then it would go up that way. Now, as you're doing something like, if your aorta has some calcification stuff there. So yeah, stenting for 1 or 2 arteries, 3 or more arteries, then it's statistically speaking better to go to the full open heart. Big thing. That's it. They do bypass grafts for people with only 1 or 2 arteries if they're so significantly stenosed that you can't just stent them. But then we get people, had a stent 10 years ago and now they're proceeding with coronary artery bypass graft. There you go. I did put that picture in there. I've looked at this for weeks. Yeah. So how do they get to your heart? Through your sternum, and that incision is called a median sternotomy. Yep, open you up, do that, close you up with wires. Yeah, think about it as like an open reduction internal fixation in terms of the bone going back together. And how long does bone take to heal? 6 to 12 weeks. So how long do they have to do this for? 6 weeks. Yeah, and then be careful for the next 6 weeks. And that's all your cardiac rehabilitation, all that kind of stuff. So what do they use to patch around the blockages? Saphenous vein, which comes from your leg, or it goes all the way up. Like sometimes they'll take it from your thigh. Yeah, yeah, it is. And the other one is this one, which might be hard for you to read, but you will see it on the operation report as LIMA, which stands for left internal mammillary artery. Yeah. Now that's an artery that comes off up there. Either mammary artery, mammillary. Okay. I don't know. It's the word in my head, dude. Let's not pretend I know how to spell either. Anyway, Lima. And sometimes there's also a right that they may or may not use. I don't think they use both of them because then you're not going to confuse some other thing. But yeah, because it's an artery, will this last a lot longer than using a vein to do the same job? Yeah. And because it's at original source at one end, you're going to get better flow characteristics. Yeah. Now they can do things where they'll take this, attach it to there, and then do a second attachment further down. And same with these. They can use one bit of tubing to plumb past 2 blockages. Yeah. So just because it's cabbaged by 3 or 4 doesn't mean they used 3 or 4 grafts. They could have used 2 grafts, and each of them did bypassed around 2 blockages. Yeah.
That means
no, because I mean, to some degree, your arteries are as well, but your blood vessels are a mesh network in your veins. So if it can't go down, if you've taken one of them out, it'll just go up the other one. Yeah. So you've got superficial veins and then deep veins and so on. So it'll just go another pathway. Yeah. Yeah. So what are our sternal precautions? Yeah. For how long? Yeah, so nothing heavier than a large bottle of milk is what I say. Now that said, you pick a standard front door, that's going to be heavier than 3 kilos. Yeah, mine definitely is. Mine will knock. Scarlett weighs 15 kilos and it'll knock her over. That's the fire doors in apartments. Yeah, so if you tell them 3 kilos, but their front door is more than 3 kilos, yeah, Are they going to listen to you or just open their door? That's all. Only works coming one way. Can't do that the other way. You need the like Star Trek doors. So yeah, external precautions are different in every hospital. Yeah, in our hospital you can use a forearm support frame. I'm going to say at Westmead because I'm picking on them. You're not allowed to. Yeah. So who's the forearm support frame when your patient can't use a forearm support frame? You. Are they leaning on you like they would lean on a frame? Yeah, that's it. So it's not actually any different. And then other variations on the theme. So yeah, always remember, there is a paper that exists that describes somebody surveyed everyone, and they were all different, which means they're all made up locally. That's the important thing about sternal precautions. Sternal precautions. They're all just invented. Like somebody just goes, I reckon this is true. It's not true. Yeah?
Jenny had a rant about this.
So the problems are very rarely that your sternum like separates and starts clicking. And the number one time I've seen that is somebody with epic COPD or something like that goes into coughing fits. Yeah? We get them to do this. Do you think that does anything? Like I've had busted ribs and holding onto it didn't do a goddamn thing for my pain. That's all. Nothing. And it was the worst because I had busted ribs during hay fever season. And sneezing was like, I'd breathe all the way out and then go, and still be in tears. So yeah. This is all just placebo, and you just like the fentanyl. Like give them as much drugs as humanly possible until they want to vomit, then move them. How many patients have we had vomit when we got them up because they've done that? A few of them. It's still better than the alternative. That's all. So risk relative to stent. Well, stents have a shorter lifespan to some degree, but then cutting somebody open. So the problem when the sternum is a problem is infection. Like if you get an infection through that wound or into the bone, that's the actual sternal problem. Not lifting anything more than 3 kilos doesn't freaking change the fact that some bugs got in there to begin with. And that's the common problem that I see. Wound infections, which have nothing to do with whether they use their arms or not. Yeah. Classic way to get a wound that dehisces is, say, somebody that's a bit of a cannonball shape with large bosoms. Is that going to put a lot of stress on there? Yeah. That is bad for your wound. That is more than 3 kilos of weight on your chest. That's all. And or binder and all sorts of stuff. They have all sorts of things that they use. Now, anyone in here actually play violin or something? The worst Asians. You're the worst Asians ever. So, I'm not saying there aren't people that can't read that music, but I can't. Yeah? Like I know the tune, but I get the feel of the tune without having to know the words. Yeah? Flight of the Bumblebee. Play that at some point. But it's like, guys that are shredders on guitar also play it on guitar. Like, I could have put Turkish Rondo up there. I could have put Bohemian Rhapsody up there. Wouldn't matter. Like, the tune without having to know the notes. And in the same way, don't try and read the ECG if it's just going to confuse you. Yeah? You just have to have the vibe of what is going on. And if somebody looks like they're dying, they're probably in this little top section here. Yeah? Does any of that look like it's going to be good for cardiac output? No. You reckon their eyes will roll back in their head and they will just not be breathing or talking to you. Yeah. That's it. And so the rest of it is just variations on exactly how sad is this person. Now, SVT is supraventricular tachycardia, which means your atria is causing the tachycardia, as opposed to VT, which is ventricular tachycardia, where the ventricle itself is creating a very fast rate. The way to think about that is, see the QRSs in SVT? See, they're nice and narrow. So the narrow QRS means AV node and your ventricle is doing okay. Anything that is not a narrow QRS is ventricle sad phase. Does that make sense? Now, we had a patient that was going into ventricular tachycardia somewhat regularly, but he was day 6 post-cardiac surgery, and the ICU team wanted him to get out of bed. Did we get him out of bed? Yeah, we did. Remember, you and I stood him?
Yes.
Did it go well? No, but we put him back to bed, and then the next day he looked better, and did you and I stand him up? And did he die? So we put him in a chair. I'm not saying any of that was sensible or not sensible. He still had the frickin' pad stuck to him and the crash trolley in the room. But he's day 7, and if we don't move somebody and have them lie in bed for 7 days, you reckon that's also a risk of death? Yeah. Now, you're in ICU. You reckon the crash trolley and the crash team are like 4 meters away? Yeah, that's it. So all done with the view that we are monitoring and we will undo our problem as quickly as we can to solve the problem. Yeah? And that's what those words mean. There is somebody that can read the music that will tell you all these things. And it's your job to go, balance of worried about this versus worried about that. Sometimes we wait a day, but we're already at day 7. So do we have any more days we should wait? No. Do we have the permission from everyone concerned to have a go? Yeah. We don't have to follow instructions to say they have to be in the chair. And what did we do? Tried to stand him twice. Didn't work, back to bed. The next day we stood him, but did we get him to step? No. We just stood him up. It went well. We moved the bed out, put the chair in. Then the next day we stood him up and took some steps. Yeah? Levels of increasing probability of not hurting him. Yeah? Don't do it all at once. Yeah? So, that's all. Feel somebody's pulse. If their pulse feels even, are they in an even rhythm or an arrhythmia? Even rhythm. And your brain can work that out pretty easily. Yeah? You've all listened to music. You know what an even rhythm is. So if it's arrhythmic, it's arrhythmic. And then part B is it fast or slow? Yeah? That sound fast? Yeah. Yeah? That's probably like 20 to 30. Slow. So, yeah. So anything within that kind of 50 to 120 range is okay, as long as they look okay. And if they don't look okay, go and get the numbers and or they're hallucinating or other weird things happening. Yeah, but feel pulses. It's so much easier to work out somebody's heart rate by feeling it for about 3 seconds and going, it's fast or slow, than it is to actually count it accurately. I realized if I measure it for 15 seconds and try to do the math, which I can do, I'm less accurate than just guessing. I'm like 110. Like if I pick it within 2 seconds, I'm better than trying to. We discovered you can't count past 6. Physios can't count past 6. Never.
Yeah.
How many was that? I don't know. Like, oh, are you counting? You're like, how many is that? Yeah, 2 more. 2 more what? That's it. Don't bother. Like, if you know that trying to do this properly is not going to be accurate, then don't try and be accurate. Just try and be within this block. Yeah. Like, I know that this is within this block and it's even or uneven, and we're pretty happy with that. And then you can check that very quickly when you're walking down the hallway. You can hold somebody's hand and feel their pulse at the same time with your finger. Yeah. That's it. Don't trust the freaking SATS probes, particularly if somebody's doing this because they're a bit stressed or had Ventolin. This is vaguely important in the sense of all I really need you to understand is what part of the heart is the QRS? Atria or ventricle? What part of the heart is the T? No, not refill, repolarizing. This is electrical activity. So depolarizing, forget movement. Movement comes after the depolarizing. Depolarizing triggers movement. Repolarizing is part of the relaxation and refilling, but it's really the repolarization is moving the calcium back out again. Calcium moves, calcium unmoves. Yeah? Depolarization, repolarization. The important thing is that the letters S and T mean ventricle. So if you see the letters S and T in a sentence, is the ventricle happy or sad? Sad, because nobody should write down ST looks fine. That is, yeah, it's STEMI. ST, elevation, myocardial infarction, or NSTEMI, which is, yeah, how do you know somebody's got a non-STEMI? It's written down, but what would they be using to say somebody's had an MI? Troponins, yeah. And you can look at the heart and go, well, that's not moving. Should be moving. That's it. So you can have ischemia and infarction without ST changes. Yeah, that's all. Just the classical thing and the not classical thing. So the non-ST ones, particularly in women, they're the ones that, people struggle to detect. So yeah, just remember, QRS is the ventricle depolarizing, which is actually passive to some degree. Yeah, imagine you set a mousetrap. That's the energy. That's ATP. The depolarizing is triggering the mousetrap. Yeah, so that is effectively, you've already set the mousetrap. The potential energy becomes kinetic energy. Yeah, and then you need to reset the mousetrap. What do you need to reset the mousetrap? Cheese. What is the cheese in this instance? ATP. Yeah? And then what is the mouse? Calcium. Make sense? So, you have nodes, SA node, which is your pacemaker. The way I think about it is that has an inherent clock rate of 120. Yeah? And as your heart rate is less than 120, what is telling your SA node to be quiet? Specifically, what is the nerve that is doing that? Vagus nerve. That's it. And that's why you're 60 to 100. Cut the vagus nerve, your heart rate would be high, and you'd only be at the whims of your adrenaline. Yeah. The next in the chain is the AV node, which makes this nice and narrow. And these bundles of His, Purkinje fibers, and all those words, think of them like nerves. What does a nerve do? Get a message from your spinal cord to your biceps quickly, so it doesn't have to like physically walk there. They're not nerves, but think about them like nerves, and they increase the speed of a depolarization to get all your ventricle to go at once. Does that make sense? Drink wine. Back to what we talked about before, your physios. You can modify a whole lot of their risk factors. I don't know. Mine is drinking wine. Actually, I want to talk about this, but we won't do it from here. This is just some. This is saying if you are sedentary all day, which is these people, 12 hours of sitting on your ass, you cannot out-exercise. This is exercise down the bottom. You cannot out-exercise your sitting on your ass all day. And in fact, see what this line does as you do more exercise? Does that increase your mortality or decrease your mortality? Increase. Yeah? Yeah. Yeah, you'll actually die sooner. Yeah, because you see these people up here? Yeah, you'd be this side of the curve. Yeah? Yeah. Yeah. Yep. 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 Yeah. Now, where are we? We're maybe at the 6 or 8 hours of sedentary, so we're down here. Yeah, because we have stand-up jobs. Yeah, so we're in this section. Yeah. Now, again, doing some exercise is better than none, but I think past this maybe 40 minutes of exercise, or somewhere in the 20 to 40, yeah, per day. That's it. More than that is not necessarily better. Yeah. Well, 40 minutes a week would be somewhere in here. Would still be better than doing none. So if you just exercise for 40 minutes once a week, what's 40 divided by 7? 6 minutes. 6 minutes would be about there. Yeah. Well, about there. There you go. Again, all these things are made up for simplicity, not for specificity. Yeah? You reckon your response to exercise is the same as mine or different? Yeah. That's your job as a physio to determine whose response to exercise is what response to exercise and whether they need to supplement with red wine. Tomatoes. Yeah, now some people are allergic to tomatoes.